the truth about breaking your water. In today's video, we will explore everything there is to know about artificial rupture of membranes. 1. What is artificial rupture of membranes? 2. Why and when is AROM recommended? 3. The step-by-step AROM procedure. 4. What to expect? Sensations and aftercare. 5. Weighing the options, benefits, risks and alternatives. 6. Special considerations and your birth plan. Many women have heard stories about what it means to have their waters broken by a doctor or midwife. A common myth suggests that this procedure instantly makes labor much more painful and difficult to manage. People worry that it is an aggressive and unnatural step in the birth process. This idea can cause anxiety for expectant mothers who are already feeling vulnerable. It is important to look past these stories and understand the medical facts. The truth is that this procedure, known medically as an artificial rupture of membranes, can be a helpful tool to start a labor or help along a labor that has slowed down. While contractions can become stronger after the waters are broken, this is not always the case. For many women, the change is gradual and manageable. The main goal is to encourage the baby's head to apply gentle, effective pressure on the cervix, which helps it to open. AROM is common, used safely for many years, and performed for specific medical reasons. Knowing why it is suggested and what it involves can replace fear with confidence. In simple terms, artificial rupture of membranes is the intentional breaking of the bag of waters that surrounds your baby. This bag, called the amniotic sac, is filled with protective fluid. When artificial rupture of membrane is performed, a small opening is made to let the fluid out. The baby remains safely inside the womb. The purpose is to start contractions or make existing ones more effective. The intact sac can cushion the baby's head from the cervix. Releasing the fluid lets the head press more directly on the cervix. That direct pressure helps trigger hormones for stronger, regular contractions. AROM can be part of an induction or used to help a stalled labor. Sometimes a cook balloon or a hormone pessary like cervidil is used first to soften the cervix. Your team assesses your situation to choose the gentlest approach. AROM is one tool among many to support you during childbirth. The ideal time for AROM is when it is both safe and likely to be effective. The baby's head should be low and well engaged in your pelvis. This helps prevent the cord from slipping when fluid is released. Your cervix should be soft and at least a little dilated. A soft, partially open cervix makes artificial rupture of membranes easier and more effective. History matters. Prior vaginal births or being later in pregnancy can favor going straight to AROM. Before artificial rupture of membrane, the clinician confirms baby's position and cervical status. If conditions are not right, they may wait or use another method first. After a previous cesarean or fibroid surgery, balloon methods or AROM are often preferred. A cook balloon followed by artificial rupture of membranes can be a gentler, safer route. This stepwise approach avoids excess strain on scar tissue. Your plan is personalized to your safety and progress. The process is quick and performed with great care, with you lying comfortably, often with a pillow under your hips. They explain each step so you feel prepared and can relax. A gentle vaginal examination is performed, similar to antenatal checks. They wear sterile gloves and use lubricant for comfort. They feel the cervix and locate the amniotic sac like a taut balloon. A small sterile instrument called an amni-hook is introduced. It is a thin plastic hook, a bit like a long crochet hook. You likely will not see it. Their guiding fingers position it. They gently scratch or snag the sac to create a tiny tear. The sac has no nerve endings, so neither you nor your baby feel this. A warm flow of amniotic fluid begins. They keep a hand in place to prevent cord prolapse. They remove the instrument, place absorbent pads, and the procedure is complete. Many women wonder what it feels like. Most describe a warm gush as the sac is opened. It can be surprising, but not painful. A steady trickle may continue for the rest of labor. Staff provide large pads to keep you comfortable. After AROM, movement is encouraged. Walk, use a birthing ball, and change positions regularly. Gravity helps. This helps the head settle and stimulates contractions. Your baby's heart rate is checked before, during, and after. With waters broken, hygiene is key. Staff watch closely for infection. If contractions do not start, an oxytocin drip may be recommended in a delivery room. You will receive careful, continuous support through active labor. A key benefit of artificial rupture of membranes is getting labor started or speeding up a slow labor. Direct head pressure can trigger stronger, regular contractions, potentially shortening labor. It may reduce the need for hormonal interventions so your body can progress naturally. The procedure is simple and quick when conditions are right. Risks are small and managed in hospital, primarily infection, mitigated by strict hygiene. Rarely cord prolapse can occur, which is why the head's engagement is checked first. If labor does not start after artificial rupture of membranes, further intervention is needed. Alternatives include a Cook balloon catheter and a Propess pessary. The Cook balloon uses two small balloons to gently stretch the cervix. Propess releases prostaglandins to soften the cervix. Often these are used first, followed by artificial rupture of membranes when the cervix is ready. Your team explains pros and cons so you can choose what fits your preferences. Your unique health history guides your plan for labor and birth. After a previous cesarean, induction is more cautious. Strong drug-stimulated contractions can stress a scar. A mechanical method like a Cook balloon followed by AROM is often preferred. This encourages the cervix to open gently and safely. After major uterine surgery, a similar cautious approach is used. Share your full medical history so the safest plan can be made. Ask why artificial rupture of membranes is recommended for you, how ready your cervix is, and your baby's position. Also, ask what the plan is if labor does not start after AROM. Inquire about room availability and when monitoring begins. AROM works best when the baby is low and the cervix is softening. Communicate openly. Your team is there to answer questions, address concerns, and support a safe, positive birth.